Hey everybody, I'm Mike Krupa, and I am on a mission to teach employers just like you how to better manage your health insurance plans. And today we're going to talk about reference-based pricing and the lessons that I have learned by implementing and maintaining reference-based health insurance plans over the years. It is one of the most effective ways to save money on your health insurance plans. And so my goal of this series is to teach you about what reference-based pricing is, if it's something that you're considering, or if it's something that you already have in place and you're looking for ways to significantly improve it. I think you'll get some value out of this video as well. So today I'm going to talk about the lessons learned over the past many years of implementing and maintaining reference-based pricing plans. And the first one is that the savings are legit, and this is just a math formula. But when you implement a reference-based pricing environment for a health insurance plan, you can expect 20 to 30% savings on your medical plans, sometimes even more than that. And I'm going to explain what reference-based pricing is and how it can actually result in lower costs. And to do that, we need to first kind of define what is an insurance carrier. How does it work today in terms of the payment? So let's just pretend like an employee goes in and they get a procedure, and the bill charge from the provider, that's before any type of insurance discount, is around $10,000. Well, the way a typical insurance carrier will work is that they then have a contract in place with that provider, which in its most simplistic terms will provide some sort of discount off of that bill charge. And in this case, it's a 62.5% discount. So you start with a $10,000 bill charge, you get a 62.5% discount. Again, that's illustrative. Gets you to a provider payment of around $3,750. And that provider payment is both the patient responsibility and it's the employer responsibility as well. And when we back into what that actual procedure would have cost as a percentage of Medicare, Medicare being 1.0, this turns out to be about 250% of Medicare, meaning it's about 2.5 times what Medicare would have paid for that exact same service. Okay, so that's kind of how an insurance carrier works, right? You go in to the provider, you present your insurance card, it's got a logo on it, and they match that logo up, they know you get a discount, and boom, there's the charge that will end up getting paid to the provider. Now, in a Medicare example, the discount is completely obsolete. It's more just an illustrative discount than anything, because what ends up happening is in Medicare, you start at a 1.0. Medicare is the biggest purchaser of healthcare within the United States. And so what we're doing in a reference-based pricing environment is we are not paying on a percentage discount. Why? Because we know that egregious providers exist in insurance carrier contracts today. And the reason we get savings when we move into a reference-based pricing environment is because simply put, we're paying these egregious providers less. And so Medicare pays these providers at 100% of Medicare. Otherwise, a $1,500 rate or provider payment for this exact same service if that patient is Medicare. So right off the bat, 2.5 times more if you're a commercially insured or an employer offering a health insurance plan. So that's Medicare. And what reference-based pricing does is it dictates to the providers how much we're going to pay them based on a percentage of Medicare. And in this example, I'm just saying it's 150% of Medicare. And I should back up here. There is no discount, but if we kind of backed into what an illustrative discount would be in this Medicare example, it's about 85%. Now we go down here into a reference-based pricing environment where we are using a multiple of Medicare. And in this case, 1.5 or 150% of Medicare. Here's kind of what we're saying, is that in this environment, a provider, they might be breaking even. They might be making a little bit of profit. Actually, they might even be losing money in this case. So let's increase that payment to 150% and build in enough room for that provider to still make a healthy profit, just not be egregious. So in this example, the 150% of Medicare results in a payment to that provider of $22.50. Illustratively, more like a 77.5% discount. So you can see how the savings is happening, right? You got a discount here, here, and here that are very different, but it's that provider payment that is different in each scenario. This is what inherently creates some issues within a reference-based pricing environment. But again, lesson number one here is that the savings is legit. And this is why the savings are legit in a reference-based pricing environment. It is literally just math. So let's talk about lesson number two. And lesson number two builds a little bit upon lesson number one, right? Why get the savings? Because we are paying egregious providers less. And so because these providers are now getting paid less in a reference-based pricing environment, the two main levels of friction that you are going to encounter as an employee are access issues and balance billing. And access issues is just what it sounds like. It means accessing a provider. Will that provider take your new insurance card? And so let's talk about what that looks like. Access issues, it means you're getting turned away at the point of service. I think what surprised me most about reference-based pricing was I had always heard about balance billing, right? People get freaked out over a balance bill because you owe more than you feel like you should owe. But the issue that's not talked about as much in a reference-based pricing environment is provider access issues. So simply put, right, you go in, you show your medical ID card, because you still get one, and on that card is the absence of a carrier logo, the absence of Blue Cross, United, Aetna, or Cigna. And it says something else there. And that provider at the front office is looking at that and they're saying, I don't recognize this insurance. And to them, in their head, what that means is I don't exactly know how I'm going to get paid. And because we don't know how and how much we're going to get paid, guess what? We're going to turn you, patient, away. And that's, in my opinion, the most disruptive thing that can happen. Even more than a balance bill, because what is more disruptive on you need to get care, you go, you make the appointment, you get into the appointment to see your doctor, and when you show up, they turn you away. And so you're expecting to get care, you don't get care, you leave feeling exactly like you did, and you're confused. Well, what do I do next? You got to expect some level of this type of friction in a reference-based pricing environment. And this can be highly, highly disruptive if you do not have the right reference-based pricing partner in place. And I want to stress that point. The right reference-based pricing partners will have figured out a way to try to make this provider access issue significantly less. You gotta be able to talk to the providers before you go in and get an appointment. So that's kind of the number one issue I see in a reference-based pricing environment. And number two is that balance billing, right? So what's a balance bill? It's when an employee gets a bill and it indicates that they owe more than what their insurance plan actually covers, right? Than their flat copay, their deductible, co-insurance, etc. Now, I will say this is a low frequency but very high anxiety event when you do get a balance bill. Low frequency meaning it's roughly 1 to 5% of all medical bills that the employer will receive for all of their employees, spouses, and dependents. And so if you have 1,000 claims, 1 to 5% of those 1,000 claims will end up being a balanced bill. And in a balanced bill, what is crucial is you have to have active involvement on part of the employee, sometimes even the employer, and definitely the reference-based pricing partner. There are processes in place with the right reference-based pricing partners to help resolve these balance bills. It's likely going to help with the anxiety employees have if they get one. It won't eliminate it, but you got to expect some level of balance billing. Just make sure you got the right reference-based pricing partner in place to actually handle those balance bills. So lesson number 3, kind of tagging off of that, which is you're not going to avoid balance bills. You may have a reference-based pricing partner that says you only get 1% of balance bills, that it's not a big deal. The fact is that you're just not going to avoid them altogether. So we got to think about like what we can do as consultants and employers to educate on what is a balance bill. That is the solution. You have to educate your employees about what these things are. And so the first thing is you have to educate them on how do you identify a balanced bill? Well, it's pretty simple. You just need two documents. Simple, but we all don't look up these documents all the time, right? So it is going to be something new. When I say we, I mean employees. But the two pieces of information that you're going to need in order to appropriately identify a balanced bill is your explanation of benefits, and that's something that's either going to be mailed to you by your insurance carrier or you are going to get electronically through their portal, right? And so it is basically going to tell you how much your insurance covers of that service. It will also say on the front, this is not a bill. So it is more likely your explanation of benefits. Now the difference when you get a provider bill, this is just a portion of it, but look right away what you see. You see credit card logos here, right? The amount that is due is $1,213, right? That is a provider bill. And the way that you know it's a provider bill is you make sure the dates of the service, all match up and everything, but do these amounts match? $30 versus $1,213? No, absolutely not, right? So the first thing that an employee should do in that case is contact the reference-based pricing partner so they can actually take action on the policies and the procedures that they have in place to help members through this balance bill. So the issue is they don't match. The action is you contact your reference-based pricing partner. But I want to point something out here because there is a misconception about balance billing and that this is a new issue. Well, it's a new issue in a reference-based pricing environment because we know ahead of time it's actually going to happen. And because we know ahead of time it's going to happen, we can work with a reference-based pricing partner that has the policies and procedures in place to tackle this when it happens. But guess what? This happens all the time on a carrier network plans as well. We just don't know it's happening because there's no mechanism within a carrier plan to understand if people are actually getting balance billed. And if I'm a betting man and you send out a survey to your employees and you're in a carrier network arrangement, I bet you somebody within your employee population has had a balance bill with one of the major insurance carriers, and it would probably surprise you. So while we have to deal with this issue ongoing, it's not a new issue. It's just now we have processes to help employees through this. Now, lesson number 4 is that reference-based pricing plans, they require what I call active plan management. So if you think about an employer that is fully insured with one of the major insurance carriers, literally everything, medical claims, pharmacy claims, customer service, provider service, medical management, you name it, it's all under one roof. And what I found is a lot of employers today, when they're in a fully insured environment, you get the renewal, 45 to 90 days ahead of your effective date. They work with their broker to try to negotiate that renewal, maybe use some competitive leverage to try to get that number down. But then after it's finalized, you go through open enrollment and that's kind of it, right? And then the renewal comes up the next year and you worry about it then. That is not the case in a reference-based pricing environment. If you want this plan to be successful, they require active plan management. It is not set it and forget it type of plan. So you got to know that going in. And I think one of the most effective ways that I have found over the years to be able to better manage these plans is the simplest way as well, which is you just gotta have regular, at a minimum, monthly touch bases with all of the partners within the health insurance plan to be able to use that as an opportunity to identify and resolve problems quickly. And I mean, here's what I mean, right? You talked about a fully insured employer, kind of everything under one roof, all the different services. But when you move into a reference-based pricing environment, you will inherently have a ton more partners. You're going to have, well, to start, you and your broker or consultant. You're going to have a third-party administrator now who is basically paying the claims, adjudicating those claims. You got an RBP vendor, reference-based pricing, who's doing a handful of things. At their core, they're a repricer, so they're the ones that are actually looking up that percentage of Medicare, repricing that claim to 150%, and then telling the TPA what that payment amount should be. They're also auditing bills to make sure that they're accurate. Think like looking at your credit card statement to make sure all the charges are correct. In addition to that, they are an advocacy partner. They're the partner we want employees to go to if they have issues. And I'll say that is a good RBP vendor if they're doing all those things. Not all of them do those three things, and not all of them do those three things well. Next, you're going to have a data warehouse because you're going to want to be able to analyze what's going on within your population, what you're seeing from a utilization standpoint. You're going to have a pharmacy vendor who is going to be, somebody different than the reference-based pricing vendor. You're going to have a medical management vendor, somebody who's handling all the pre-certifications when employees are actually going in and getting elective procedures. And then a stop-loss partner. This is the partner that is protecting you against the largest claims that you could have. And so what is crucial is you're meeting with all of these partners at a minimum on a monthly basis. And maybe after that plan has been in for a very long time, maybe you can scale that back. But I would say at a minimum, you should do monthly calls with these partners. And as you are setting up this plan, I would also recommend in the preceding 3 months and the succeeding 3 months of the effective date that you highly consider implementing a little bit different of a cadence. Maybe it's bi-weekly or maybe it's weekly. When the plan goes live, you're going to have issues that pop up. Employees are going to face some anxiety that they didn't before, right? If they have access issues or balance billing. So what you want to do with these, call it bi-weekly or weekly calls, is you want to use that as an opportunity to identify the problems that you're having in the plan so you can resolve them. What you don't want to happen in a reference-based pricing environment is all your communication with everybody is just over email, because issues that pop up do have a different level of urgency. And the more often you're doing these calls and these touch bases, the quicker it is to resolve problems. It's the single most effective way to resolve issues in a timely manner with the friction that you face in a reference-based pricing environment. So again, lesson number 4 requires active plan management, requires involvement on the employer and on the broker. Now, lesson number 5 is about a new concept called direct primary care. And the reason I bring up direct primary care is because this is one of the ways that you can eliminate and mitigate some of the issues or the friction that we see in a reference-based pricing health insurance plan. In addition, it also fills some of the gaps that reference-based pricing does not address. And so reference-based pricing does not address the quality of a procedure you get or how often you are utilizing healthcare services, right? It impacts the financials of the health insurance plan in its most simplistic term. We are putting guardrails up on egregious providers, but there are still other issues that exist within a health insurance plan. And direct primary care fill those gaps. So let's talk about what is direct primary care. In its most simplistic term, it is literally just a change in the payment model. It is a change in how we are paying primary care providers, where today they work in a fee-for-service environment, which means every time an employee, a spouse, a dependent goes into the doctor, they pay a fee for that service of seeing their primary care physician. What direct primary care does is it changes that payment to more like a gym membership type of model. You pay a monthly fee, and in lieu of that monthly fee, you get access to your primary care provider whenever you need to see them. Let's talk about what makes the secret sauce here and what's truly different, right? Because it's still the same, it's still a primary care provider. They're still practicing primary care. But this change in payment has a significant impact because today in a fee-for-service environment, the average primary care physician is taking care of a minimum of 2,400 patients a year. See, their reimbursement rates from the carriers and Medicare has not gone up over the past 10, 15 years. And they're struggling to stay alive. And the way they stay alive is by seeing more patients and more patients and more patients. And that is exactly the reason why when the majority of Americans go in to see their primary care provider, they might wait 3 to 4 weeks to even be able to see them. And by the time they actually get an appointment and they go in, they're going to sit in the waiting room for 30 minutes. They'll finally get in to see their doctor. Maybe it's their doctor. Otherwise, it would be a physician's assistant or a nurse practitioner. And then you'll get about 15 minutes with them. And what you'll notice in the 15 minutes is they're writing notes the whole time because they're super rushed, right? And that is part of their administrative process. Because they are seeing a minimum of 2,400 patients a year, they're only blocking 15 minutes for you. That's it. And so 15 minutes is about enough time to write a prescription or give you a referral to a specialist. And that's what we see happen in traditional health insurance plans is this constant referral and then overutilization of services because your doctor just doesn't have enough time. What direct primary care does, changing that payment model, it gives that practice a very predictable revenue stream. They know exactly how much they're going to get paid now, and you're cutting out the insurance billing part of this that you see in a traditional model. No, it's just a membership model. And believe it or not, because they cut out insurance, they save a ton of money on overhead. And what ends up happening in a direct primary care environment, because of the structure of the payments, is these doctors are now seeing a maximum of 600 patients per year. So a quarter of the minimum they would see in a traditional environment. And that is the secret sauce, because what that allows for is more time with your doctor. And that is exactly what is needed within American healthcare today. When you move into a direct primary care environment, you will get access to same and next day appointments if you need it. You will have an initial 2-hour appointment for an entire download of your family history. And you will have hour appointment blocks set up after that to ensure that you have the ample amount of time for your primary care provider to address the needs that you came into the appointment for. The fact is that direct primary care complements reference-based pricing significantly. So right off the bat, it completely eliminates any provider care access issues or any balanced billing with primary care. Because again, you're paying that practice directly. You have a contract in place. There's no need for a balance bill because you know exactly what you're getting paid, and they have immediate access to you because they're buying a membership. So it completely eliminates for primary care those issues that we see in a reference-based pricing environment. And then I would also say that it mitigates the issues outside of your primary care. So think like specialists, think an inpatient or outpatient hospital. It's going to mitigate these issues significantly because of a handful of things. First, your direct primary care provider, I want you to think of them like a quarterback, right? They are your quarterback navigating you through the healthcare system. Where today, we just don't have that, right? And what ends up happening is you do get 24/7 emergency access to your doctor. Believe it or not, this is not used all that much, but one of the areas we see it utilized a bit is when you go in to see a specialist that you've been referred to, and that specialist says we don't take that insurance, right? We want immediate call to the direct primary care provider to help solve that. The second is, look, over the many years of doing this, it is very clear that there are providers that accept reference-based pricing and those that are far less likely to accept reference-based pricing. I call them friendly, non-friendly RBP providers. And what happens when you have a direct primary care provider that knows who these friendly, non-friendly providers are, if they can refer you to the friendly providers up front, you're automatically going to have less access issues, and you're automatically going to have less issues with balance billing down the road. That's why I see our plans that have direct primary care in place with RBP have the lowest balance bill rates that I've seen on reference-based pricing employers because of that right there. Your balance bill rates will plummet because of the access to a direct primary care partner, assuming they're actively involved within your health insurance plan. So I guess first thing I'd say about direct primary care is that it helps solve the levels of friction that are naturally in play with a reference-based pricing partner. In addition to that, it addresses some key issues that reference-based pricing simply does not. And one is quality, and two, I would say, is overutilization. So again, reference-based pricing is really putting some guardrails up on how much the plan and the patient are going to pay for certain procedures, but it doesn't determine a quality provider, right? If you go to a quality provider up front, we know that one, there's a good chance that the price is the lowest for that quality provider. Why? Because they specialize in something. Maybe it's knee replacements. They're doing these all day long. They figured out a way to keep their overhead low, and because they do it all day long and they specialize in it, they have quality outcomes, right? And then the second piece of this is because you have quality outcomes, you don't go back in for some sort of readmission. Do you know that in a carrier-driven plan, if you have a knee replacement today and you need to get that knee replacement redone because that provider messed it up, guess what? The plan is paying for that twice, right? We want to make sure we're sending to quality providers up front. That is going to help with the cost down the road. And then appropriate utilization. So I talked about how a traditional primary care provider, they just don't have a lot of time, right? And because they don't have a lot of time, most of what they can do is write you a prescription or a referral to a specialist. But when you change that 15 minutes to an hour, now you have ample time to talk about what's really happening and how you can treat the root cause of that problem instead of just treating the symptom. And this is where you can have an impact on the price of a procedure as well, right? The best part about a claim is that that claim never happens. You don't have to worry about it, right? There's no reason to send someone to a specialist if that can be handled by a primary care provider. Because guess what? When you go to a specialist, they're going to treat you for what their specialty is. If you're having knee pain, they're going to treat that knee somehow. So let's make sure we're getting the appropriate utilization. And this is probably my favorite part, about reference-based pricing is when you pair it up with direct primary care. In my opinion, it becomes a winning formula. Is it perfect? No. Is a health plan today in an insurance carrier market perfect? No. But what this does, it provides you savings, significant savings by implementing reference-based pricing. You're going to eat into that savings a little bit by implementing something like direct primary care, because you're going to pay more for primary care than you did before now. But at the end of the day, you're going to have employees that have more time with their doctors and that can actually get the issues that they have going on resolved in a timely fashion so they don't result in more issues down the road. So I can't stress enough, if there is one single way that an existing reference-based pricing employer can improve their health insurance experience for their employees, spouses, and dependents, it's add direct primary care in place. It is an unbelievable solution. And that brings us to wrapping up the lessons and talking about some social proof. So have we actually done this? But first of all, again, just to kind of wrap up the lessons, lesson number one is that you're going to get savings in a reference-based pricing environment because we're simply paying egregious providers less money. That's where the savings comes from. Number two, you will have some level of friction. Go in knowing you will have some level of friction. Set your expectations. And those levels of friction are going to be accessing providers and balance billing. And if you don't have the right reference-based pricing partner in place, that access issue will quickly become the number one issue you have in a reference-based pricing plan because of the frequency of how often it is going to happen. Lesson number three, you can't avoid these balance bills, right? You got to educate your employees on what is a balance bill so they can make sure they're identifying it to really keep them protected at the end of the day. Number four, these plans require active plan management. I would love to tell you these are set it and forget it, but they're not. You as the employer will have to be more actively involved. Your broker or consultant will have to be actively more involved, as well as all of the parties within the health insurance plan. Active plan management will make these plans more successful. And then finally, direct primary care resolves the friction points significantly in a reference-based pricing environment, and then also addresses two other issues like quality and overutilization that reference-based pricing simply does not address. So there are some significant lessons learned here. I wanted to wrap up these lessons with some social proof and talking through an employer who has done both of these concepts. And what you're going to see here is a manufacturing employer in Illinois. They have about 90 employees enrolled on their health insurance plan. They're in 13 states. Now, in 2021, 2022, when we got their renewal, they were with United Healthcare. They were facing a 35% increase from United Healthcare, and they were not budging off of that number at all. Now, we had already, with this employer, they'd been fully insured since we took them over as a client. They had switched some carriers in between. We had been educating them on self-funding and reference-based pricing and all these different things they could do to save money when they needed it. This year hit and they were ready. And so they did not take this path of a 35% increase because look at what the difference is, 1.02 million to 1.37 million in total healthcare expenses. They simply could not afford this. So they completely remodeled their health insurance plan. They moved into a self-funded arrangement. They had reference-based pricing in place. They added direct primary care. They went with a great prescription drug manager and a great medical management vendor to try to tackle everything within the health insurance plan. The results after the first year were not a plus 35%, they were a plus 11% increase, but the best part is year two, what we saw is even a further decrease. So a 9% decrease off of the first year. They're paying almost exactly the same amount in healthcare as they were prior to getting a 35% increase. And this is what is possible. And that doesn't even include what we did on the plan designs. They had two high deductible health plans in place. People were not accessing care because of the significant financial barriers. So what we did was we eliminated high deductible health plans. We slashed the deductibles in half. We gave employees the option to get free health care when they made great quality healthcare decisions. And then we added in a lot of different programs as well. So the point is that they now had access, affordable access to care, prescription drug copays now, right? So we significantly improved the plan design. And I think that's probably one of the biggest misconceptions with reference-based pricing is you go in there, you're going to save a ton of money, and guess what though? You're going to have a lot of noise at the end of the day. Well, when you add in direct primary care, you can significantly mitigate that noise. You can improve your benefits, which is huge in today's environment. And let's talk about, again, why do we have savings here, right? We're spending more on primary care. Sure, we're paying providers less. So where is the rest of the savings coming from? Well, it is coming from utilization. What was really, really interesting about this case study is they had 60 employees who took the direct primary care plan. They had 30 that did not. And when we compared the results, we saw a difference of ER visits, urgent care visits, inpatient hospital visits, labs, x-rays, the number of scripts, and specialist visits. We all saw a decrease in employees that had a direct primary care provider. And these are utilization differences that we see across all of our plans that use direct primary care. And I think one of the ones that sticks out to me most, and maybe this is because I take medication, is on average, these types of primary care providers are prescribing at a rate of 40% less. Why? Because they have more time to spend with the patient, resolving root cause issues, not just resolving the symptom with a prescription drug, right? This is what we're seeing in it. So look, I think my message at the end of the day should probably be clear, but if you are in a reference-based pricing arrangement today and you're experiencing a level of noise, your employees are experiencing that level of noise, and it's just given too much heartburn and anxiety, I would strongly consider looking into direct primary care and building a health plan around that. You will pay a little bit more. It will eat into your reference-based savings, but you will automatically improve the access to people, which will inherently reduce costs down the road. So if you're considering reference-based pricing, definitely look into direct primary care along with it. I hope you found the information in this video helpful if reference-based pricing is something that you're considering or just looking for ways to improve it. In the meantime, have a great rest of the day. I really appreciate you listening to this video. Thanks.